You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, what you need to know if you are in pain, some of the newest treatment options. On the show today, we have a medical doctor that says that there are millions of people in the U.S. suffering that don't have to be. There's even people getting surgeries, scheduled for surgeries, that surgery can be avoided with some of these implantable devices, injection therapy, stem cells. Big topic today. With us, we have Interventional Pain Management physician, Dr. Sanapati. Dr. Sanapati, welcome to the program.
Thank you, Randy.
Now, before we get into today's topic, for people that don't know your center, I guess you have like 14 centers stretched across like 4 or 5 states. Who's the typical pain patient you see, and what are the different services you offer?
Our typical pain patient is a middle to elderly age patients. They're either working or retired people. These people have gotten hurt during their lifetime, either from accidents or from the work-related injuries or from degenerative conditions in their spine. And majority of these patients have back pain.
Okay, so about 70%, I think what you told me, of your practice is dealing with back pain.
Back pain, yes.
Okay, so now is it true at the top of the show, people literally have been scheduled for surgery, like a fusion surgery? They get to you,
yes,
and you can avoid surgery.
Yes,
that's
absolutely
happened?
right. Yes, that happens several times. We see it more and more. When the people go to their primary care providers, majority of them are tried on medications, unfortunately, and we see the big opioid epidemic because of that. So it's very important for these patients to go to the trained interventional pain specialists early in their problem.
Have you had people get off pain meds?
Several of them.
Like every week in your practice?
Yes, absolutely.
People that get off pain meds, really?
Get off pain medications, and they couldn't believe it.
Even the
They were
strong
scared.
ones?
Yes, they were scared to go off of the opioids. But once we reassure them and we let them talk to the people who have actually gotten off their medications, they feel comfortable with that, and they want to try it, and they have gotten off their medications.
Okay.
And we do offer the treatments to get them off the medications. So our procedures and our interventions help them to go off of these medications.
Okay, so you have 14 locations. What's your role in the centers?
My role is as a medical director, and also I'm a very busy physician offering the treatments. So
Okay.
I oversee the operations and also provide the treatments.
So now we should mention, you teach other medical doctors from all over the world
Yes.
the things we're talking about today
Yes.
on the
We
show.
actually have a clinic in India. We started
Is that right?
pain clinic, yes. And we have physicians there offering these treatments
Now,
under
at the
our
f-
guidance.
Now at the top of the show, you know, I said there are millions of people that are in pain that don't have to be. Do you agree with that?
Absolutely. I agree with that.
Like, what do you mean?
I mean, the people, most of them are not aware of the options they have.
Okay.
Again, we go back to they have to go to the right physician who is well trained in these treatments. And the way we are different from most of the other pain providers is the way we were trained. I was actually a general surgeon, and then I had additional training, a residency in anesthesiology, and then I did an extra year of fellowship in pain management. After that, I have 20 years of experience, and I have been learning all my life. So being a general surgeon and then anesthesiology and doing a pain fellowship, I had more experience in offering, doing these procedures. I had more expertise and special skills being a surgeon to do a lot of these surgical procedures on these pain patients, which majority of the pain physicians are not comfortable with.
And it doesn't cost more to go to guys like you. I mean, it's covered by insurance.
Yes,
Right?
absolutely.
So if somebody's in pain, in addition to their primary care physician, should they say, I need a referral to an interventional pain management physician?
Absolutely, yes.
Can they go to you first?
Because most of the problem we see is they started on opioids. See, you don't want that to happen. Once you put the patient on the opioids and continue that for a longer time, they're okay for acute pain and for short term, but if they are continuing on the long term, that's when the problems start.
But you get people off opioid medications all the time.
Yes.
Like people can't drive a car, now they can drive a car.
Yes, absolutely right. People who lost the driver license, now they can get the license back.
Is that right? And you see
Absolutely.
that all the time.
We see all the time.
Do people go to you because they're afraid of surgery? They're trying to avoid surgery?
Not really. If surgery is indicated, it is indicated.
Okay.
But majority of the people, they don't need surgery. So that's where we come into the picture. We make the right diagnosis. A lot of the physicians, other pain physicians, they don't make the accurate pain diagnosis because they're not trained to do that. So the easiest way to do is somebody comes to the office with acute pain, you can start them on non-steroidal anti-inflammatory medicines. Common ones are Advil, Aleve, ibuprofen, Motrin, something like that.
Okay.
And you try that. Sometimes it works. That's great. If it doesn't work, then what you do? Then you can send them to physical therapy and things like that. So that sometimes helps. That's okay. But if that doesn't help, then they should be referred to a specially trained interventional pain management physician. But you shouldn't be starting them on opioids and continue them
So
for
that's
long
going
time.
on in the industry.
That's going
where
on in the industry.
the first line therapy is
Yeah.
opioid.
Most of the studies and the statistics show that most of these opioids were given by primary care providers.
Okay, interesting. So in your hands, let's start with low back pain for a second. We're going to talk about shoulders, knees,
Yes.
neck pain. But with back pain, injection therapy. Describe what kind of pain injections work great for.
Oh, for the low back pain, the injections depend on where the pain is coming from. So first the patients come and then you do your history taking and then you do physical examination and then in your mind you have an idea where the pain generator is going to be. But then you have to identify and confirm the generator before you do the treatments.
You have to confirm where the pain's coming
That's
from.
right.
Okay.
So that's where you review the investigations. If they had a CT scan, MRI, X-rays, you go through those investigations and you try to find the cause. And after that, you confirm that by doing the diagnostic injections. And sometimes if you're very sure about the diagnosis, you can do a therapeutic injection.
So let me get this straight. So they go into your office.
Yes.
You've got the imaging, you've got their medical history,
Yes.
you got a little bit of rapport with them. You do like a test injection to
Yes.
see if it's even going to work.
Absolutely.
And for some people, they're going, my pain's gone.
Oh, some people, they are surprised, pleasant surprise. They're shocked.
So that helps you determine, okay, that's where the pain generator is.
That's right.
And then you move to the therapy.
Therapy, that's right.
And how long does something like that last? Like in a perfect scenario, like 3 months, 6 months?
The initial diagnostic injections are done in 2 stages. The first one is actually a diagnostic block. Second one is like a confirmatory block. That's the second diagnostic
Second block is a what?
It's called as the second diagnostic block or a confirmatory block.
Okay.
It's confirm
that that's where the pain is coming
right.
from. Okay.
It's done with a different medicine. So sometimes you want to rule out like a placebo effect. So it's better to do more than
right?
one
Okay,
injection
okay.
to make sure to confirm that.
And that can last for a long time.
That's right. The diagnostic injections usually last weeks to months. So after the diagnostic injections, we do therapeutic injections. These injections last 3 to 6 months.
Okay.
Sometimes in the place of diagnostic injections, we offer ablation procedures. The ablation is actually like killing the nerve. It causes degeneration of the
Like
nerve.
you burn the nerve a little bit?
Yeah, either it's a burning or freezing, or you can use a chemical, and the chemical will cause a degeneration. So it can be done with 3 methods: heat, cold, or chemical.
Is that right? And
Yes.
then the pain goes away.
Pain goes away. It kind of kills the nerve, but the nerve can regenerate after 6 months.
So if you're giving them an injection that lasts, let's say, a half a year, but isn't that just a Band-Aid?
No, it's not a Band-Aid. It's part of their treatment. You have to look at pain management as like any other disease. Like if patients have diabetes or hypertension or a COPD, these are chronic conditions. You can't give a pill and expect that to work for a lifetime. It doesn't happen that way. Pain management, especially it is a chronic pain, we are talking about chronic pain here, not acute pain. Chronic pain is like any other chronic medical
Going on
condition.
for a long time.
A long time. And you have to manage it on a regular basis. The patients have to follow strict nutrition protocols. And then some people may need counseling depending on how much anxiety and depression they developed from chronic pain over all these years. And then they have to have a structured exercise program to build core strength, especially that's very important.
Okay.
And these injections are needed on a regular basis, not every day.
So if they're
but
out
several
of pain,
months.
they could go back to exercise.
Yes.
Or physical therapy.
Yes.
And things like that.
All
there
healthy
people
habits.
Are there people that you give an injection to when
Yes.
you find the pain generator and then you don't see them again because they're out of pain?
Yeah, it depends. Sometimes we don't see them for several years. I have patients I do an injection and they come back after 3-4 years and they want the same injection. But I tell them I have to reevaluate you again. This may be a different pain. Then we, if needed, if it is the same after physical examination, if I think it is the same condition, it didn't change much, I will do that procedure. If it seems to be a little different because I have already the documentation from the previous visit available to me, so I review that. And if it doesn't match, then I'll do investigations again and start them on treatment again.
Now let's talk about, so a lot of people are taking opioid medication for their pain.
Yes.
So I guess you're able to, under a scope, fluoroscopy, looking at a screen, you can inject medications instead of like 100 milligrams of whatever, you could give 1 milligram in the spot. And
that is, are you talking about pain pumps?
I'm just curious. I don't know. I was just
Yes.
from interviewing you on the phone, I wanted clarity.
If patients are on opioids, then if they are on higher doses of opioids for long term, that is a concern.
Okay.
Because higher doses of opioids taken by mouth or by patches, like fentanyl patches, they can cause side effects. People become drowsy and they have difficulty thinking, they have memory problems, they have difficulty driving. A lot of people lose license when they end up in accidents and they go for drug testing and they test positive for opioids, then they lose their license.
All right.
You know that. So to give them good pain relief with non-opioids, we have a lot of things to offer. So we can taper them off the medications gradually while they're on our treatments.
But you are injecting certain areas with medications?
Yes, where the pain is.
With small dose?
Small. It doesn't need to be an opioid. These are usually local anesthetics or steroids.
Is that right?
Yes, it's not opioids.
Like you're just injecting some sort of anti-inflammatory in that area?
That's right. Or numbing medications.
So would you say, if let's say, of the millions and millions and millions of people that are on opioids, do you think a lot of them could have been avoided?
Absolutely.
If they saw an interventional pain management first?
Absolutely. They get to see the right doctor. That's very important.
Now, what you're saying sounds logical. So if the first line therapy is opioids and you're saying maybe that shouldn't be the case, why aren't they all doing it that way? The primary care physicians. Don't they know what interventional pain management guys do?
I think they're doing it. In the past, I have seen more physicians, especially the physicians that were trained several years ago. They were not really aware and trained with the new modalities of the pain management treatments. Like when I entered into private practice in our area, a lot of the people didn't know about pain pumps and spinal cord stimulators.
So let's start with spinal cord stimulators. What is it and how do they work?
Spinal cord stimulators are implantable devices.
Okay.
These are like, you can compare with a pacemaker.
Is that what these are right here?
Yes, that's right.
Okay.
This is actually the spinal cord stimulator, electrical pulse generator.
All right.
This actually sends the electrical impulses through wires. The wires actually go into the spinal canal. So the wires have electrodes on them. The electrodes stimulate the pain pathways, the nerve fibers in the spinal cord.
So the message to the brain that signals pain is now like interfered
blocked
with.
at the spinal cord level.
Is that right? And this just what? Pulses?
The pulses are sent, this is the generator, this is the battery. It's implanted in the body. This sends out impulses through the wires, through the electrodes in the back. And they match the pain signals from the body.
And this is very effective for what kind of back pain?
It's effective for back pain. And if you're asking me specifically about the back pain, this is a back pain they have that for many years. And they already had tried medications, therapy, injections, and some people had already back surgeries multiple times.
Okay.
So they're not better. So that's when we try this.
And where does that go, like on your body? Like where do you implant it?
Usually we implant either in the belly, under the skin, or in the back.
So you can't really see it that much? Just a little tiny
No, you can't see it. It's very small.
And how often do they have to get it maintained?
The replacement is 10 years for the rechargeable. This is rechargeable. You can actually charge it from outside.
So it interferes with the signal to the brain. I mean, it sounds like like a good one to do.
It is good
like
because the advantage of this is no medication. There's no medication involved in this. It's purely electrical stimulation.
So who does this work best for? Because it sounds good, right? I mean, nobody wants to take medications. I mean, the only reason they do is because it works. They're out of pain.
Sure.
So what?
This works great for the people who have back pain for many years. They're suffering. They have hard time getting in and out of the car and doing their household activities. and they can't stay in any position comfortably for more than a minute. They keep moving around too much.
Is this from the disc pain? Is it from something that's rubbing onto the nerve?
It could be anything. It could be disc or facet joints or rubbing on the nerve. So it's just
hitting the nerve and like confusing the signal to the brain.
Yes, that's right.
Well, it seems like everybody would want that.
Everybody will want it. They love it. I have several patients on this. Like one guy is a middle-aged patient. He was driving like 10 hours a day, and he was on so much pain medications, and the medications were interfering with his driving abilities and memory, and he was getting confused. So he had tried injections, failed. He had 2 back surgeries, failed, and he was looking for something like this. And they go through a psychological evaluation, and then they go through a test drive. The test drive is for a week. So they actually get to try this without being implanted. So the test drive would involve...
Test drive?
Yes.
You're saying it's a test drive?
Yeah, it's called a trial stimulation.
Okay.
Yeah, it's like a test drive. So you put in this wire through a needle. So no incision, no scar on the back. It's like an injection. You put this wire through the back into the spine and then hook up to the battery outside. And they try it for a week.
Okay.
And then
in your office, do they ever say, I already feel better?
Absolutely.
Really?
Yes. And it's amazing the relief they get. And when they come back after a week for evaluation, during this week we ask them to monitor what are the activities they are able to do.
Okay.
And also how much pain relief they got. So some patients, when it works great, they get 100% pain relief, and they're able to do all the activities they haven't done for years. It's like shocking. Sometimes
really?
The patients
they could play tennis again? Or
that's right. Sometimes the patients were so depressed, having pain all these years, they can't really express how much relief they got. But the family who watches them closely every day, they come and say, you won't believe how this person is so different. He's happy, he's smiling. We didn't see the smile or laugh for a long time.
People in pain are not in a good mood.
Absolutely. It affects their social life, sexual life.
It's hard to pay attention. I mean, the only kind of pain, knock on wood, is I told you I had a bad toothache, and I was at the where the presidents are in South Dakota, and I couldn't even pay attention because of the pain. And I'm thinking that's what pain patients must live like. They're not motivated.
Yeah, once you have pain that long, then you're going to develop all these psychological problems.
So and the medications numb them.
Yes.
Right, mentally sometimes.
Yes.
So if you can get a block in there or a stimulator,
yes,
and they're out of pain, they're happy again.
Absolutely.
So that's interesting. So the family notices the big difference.
I have patients who had spinal cord stimulator implant for almost 20 years.
Okay.
And there are a few patients I only see them for the battery change. Like every 7 to 10 years, they come for battery change.
Is that right?
And they're leading normal life without any medications. They don't take any pain medications. They're just living on this.
Is that something that usually interventional pain management people do?
Absolutely.
Doctors do. Mm-hmm. Okay. Now, you brought another one. What is that?
Oh, this is called the pain pump. This is another implantable device. But the difference here is it actually gives the medication. But the medication goes into the spine.
But it's low-dose medication.
Yes.
As opposed to a high-dose pill.
That's right.
Okay.
It's a low-dose medication. It's very targeted. The medication goes into the spinal fluid.
It's like a little wire?
Yeah, there's a little tubing called catheter, goes from here into the back, into the spinal fluid. It's very thin. So the pump pumps the medication through that tubing into the spinal fluid. And this is the port where it is refilled through the skin.
Okay.
So this is another port to test if there are any problems with the catheter, occlusion, and things like that.
And again, you can test this ahead of time before you implant it.
We do a procedure called, it's a pump trial, again.
Okay.
So we directly inject medication into the spinal fluid under X-ray guidance and evaluate them. And if the patients get good pain relief and they could do the activities they couldn't do before, then they actually ask for this procedure.
Okay.
We don't need to offer this procedure. Once they see the imaging difference, they ask for the procedure. They want the procedure right away there. That's how they ask for it. I have several patients with this procedure. It can be done in different conditions. There's one patient actually was on a lot of pain medications, had 2 back surgeries, and the medication stopped working, and she was also having injections which are supposed to work 3 to 6 months, but they were working only like 5 to 6 weeks. So she wanted to go with the pump trial, and she had a trial injection, 1 dose, very small dose, and into the spinal fluid, and she had 100% pain relief, and she was walking back and forth in the clinic. And after a day, she called us and said, I want to go ahead with this pain pump implantation. That's one of them, but I have several stories.
So the procedure themselves, I mean, both of these things, it's not like a major surgery. They're back to work the next day if they wanted to be? Just a little
they're
soreness?
Very minimally invasive surgeries, and they have 1 to 2 weeks of soreness, and they can go back to work.
Now, the bigger one, is that bulgy on the skin? Does it show?
Depends on the size of the patient. Usually it doesn't show up.
Okay.
We usually put it in the loin here, so it nicely sits in right there. It's very hard to see any bulge there.
Can an 80-year-old get some of these implantable devices to block pain?
Absolutely. There's no age limit for
So
this.
it's no age limit. So do you have people literally in their 40s and 50s and 60s with these
Most of the
devices?
patients are in from 40 to 70s.
Because look, nobody wants to be on drugs. You know, there's an opioid epidemic, but it's doing something for these people. This is a way, especially the first one where it's an electronic stimulator, there's no medication at all.
There's no medication involved.
So now that's obviously for worse pain problems. The other
This is all, the
implantable
pump is also done for some patients if this doesn't work.
And what are the patient fears? Because it sounds like they would want to do this, right? So it's just their fear of the surgery, the fear of
Patients
something
are
in their
feared
body.
about surgery because these patients we're talking about are a special kind of population. They have chronic pain, they have anxiety, depression, so they need some reassurance. And we have patient ambassadors. The patient ambassadors, they already had these procedures done, so the patients feel comfortable when they get to talk to these patient ambassadors who already had this procedure done.
Okay.
So then they feel reassured and they feel comfortable going to these procedures.
Now, we're really short on time. We haven't really talked about shoulder and knee, big part of your practice. We haven't talked about stem cells. I'm going to interview your partner, Dr. Manchikati, on stem cells. But neck pain, same kind of thing? Does this work for, or is that different?
Neck pain, this works for neck and arm pains, this works for it.
Is that right?
Yes.
And injection therapy, things like that.
Same thing. You try the conservative modalities first. If they don't work, then you go to injection therapies. And if the injection therapies are not offering long-lasting relief, then you go to implantable pain therapies.
And everything we're talking about, this is covered by insurance.
Absolutely.
So do people need a referral from their primary care physician, their spine surgeon, whatever, orthopedic surgeon, or could they also call you directly?
They can call us, but then we call their physicians to get all the medical records to review. If they are referred, then it's better because we get their medical records, so we don't have to duplicate a lot of the investigations and do a lot of research. It actually speeds up the process for them. We'll be able to get them in quicker and evaluate them quicker and offer the pain relief quicker.
Now, I was telling your partner that I have a neighbor that has had a sore shoulder. I've only known him a year, but at first it was like, oh, my shoulder hurts. Now he's walking around. I see him out my window, walking around holding his shoulder all day. And the other day he said, oh, I'm in so much pain. I said, you should go in and get checked out. And he goes, no, I don't want to go to a doctor. This guy has the means. He's got the insurance. But are there a lot of people like that? And if he does nothing, it could turn into a bunch of other things. Is that true?
You're right. That's what we're talking about. Early intervention is better. You need to get to the right physician early in the game.
For these people that do nothing, what could happen?
Oh, it can be frozen. It can be a frozen shoulder.
Frozen shoulder?
Yeah, they'll constant inflammation, persistent inflammation causes scar tissue, radiations, and then now you're dealing with a different problem.
And then it moves to the neck?
It moves to the neck, head.
Okay. Yeah. Now, what about, we haven't talked about leg pain, sciatica. I know a lot of the doctors that I work with are always complaining about sciatica or leg pain.
Sciatica is a common term.
Okay.
It's a kind of layman's term. Any people having pain from the low back going all the way down to the leg, they call it sciatica.
Do you treat that?
Yes.
Is that an easy one to treat if caught early?
Yes, if caught early, it's easy one to treat. Yes.
Is that right? So we're really short on time, but somebody watching this, what do you want them to know about interventional pain management physicians?
People have to know that interventional pain management physicians are specially trained to offer pain management. They have special tools to diagnose the pain and accurately treat the pain. They do minimally invasive techniques like injections or implantable pain therapy options, and sometimes surgical procedures to help the pain and relieve their anxiety, depression, and also help them to go back to work and do the things they love to do in their life, and take care of the family and have a better social life. This is why they need to go to interventional pain management physicians.
It's covered by insurance, so they should at least get a consult.
Yes. And most of these procedures are FDA approved procedures.
Okay. And they could, and like you say, you could do a trial on them. That means
Yes.
right there in the office
Yes.
with a stimulator or an injection, and right there in the office.
They
Some
have
of them are out of
better
pain.
functioning with all the treatments offered by interventional pain physicians.
Do patients ever say, is it okay to play tennis? Is it okay to start jogging again?
Yes. Yes.
And they can? Do you have patients that
Yes,
were
we have
really in
patients
bad shape and now they're back?
with playing golf. Actually, one of the patients I had, he had his spinal cord stimulator and went back playing golf.
Is that right?
He loves it. He has this for almost 14 years.
And you know, your partner, Dr. Manchikanti, that if hundreds of thousands, maybe even 1 million of these fusion procedures or back surgeries are being performed, would you say that a lot of them, 50% of them, if they could have had some of this therapy first, they could have avoided
Absolutely.
these back surgeries?
Recently, I'm reviewing a study with stem cells in the disc, with stem cell injections in the disc. 76% of these patients avoided spinal fusion.
Is that right?
Yeah,
So it kind of
70%.
grows,
Absolutely.
puffs up the disc again?
Uh-huh. Yes, 70% of the patients had pain relief after 3 years with stem cell injections in the disc, and 40% of them have regenerated the disc, and it looked normal on the MRI.
Regenerated the disc.
Yes. And
You could actually see that it grew again.
Yeah, you compare with the MRI done after the injection and the MRI before the injection, it actually came back to normal appearance in 40% of the patients after the injection.
So that's big. Is this an exciting time in
It's an exciting time.
in your world of
And there are a
pain
lot of
management?
studies going on. Yes.
Okay, good. I want to thank you for coming on the show. Final
Thank you.
message. Somebody watching this, they're in pain. A loved one is in pain. And for whatever reason, they're skeptical. Or maybe they're just taking oral medications. They're lethargic all the time. They can't, their memory's poor. What do you say to them?
Tell them to call the interventional pain physician clinics right away and get to the correct doctor. And also, when you're deciding a doctor, make sure that your doctor is not moving away from your area. And also, you have to think about if your insurance is going to change and things like that. You have to be thinking ahead. And you have to have a shared decision making along with the doctor.
Shared decision making.
And you have to be highly motivated too. The doctor cannot help you if you're not motivated to do the right things like nutrition and structured exercise programs and all the other things that go along with injections and
you
medications.
guys are pretty progressive there. I mean, you're here in San Diego taping this, and you're at a nutrition conference.
Yes,
So you're always trying to figure out
all the ways to help the patient.
little hacks, to even
Yes.
stimulators to try
Yes.
to get people off medications and pain-free.
Absolutely. You have to offer a comprehensive multimodal approach.
Okay, good. I want to thank you for coming on the show. Good stuff.
Thanks, Randy.
All right.
Thank you.
You've been watching the Wellness Hour, news that makes you healthier. For now, I wish you could help.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.